Hi there, I'm Jim Zirin. Welcome back for more conversations. Our show is about the opioid addiction crisis in America. Sadly, opioid addiction strikes a broad spectrum of Americans, from blue-collar workers to Wall Street traders. Last year, health officials attributed at least 60,000 deaths nationwide to opioid overdose. Drug overdoses killed 1,374 people in New York City alone in 2016, or 20 in 100,000 residents, a rate that climbed for a sixth straight year and more than doubled since 2010. It's sobering. About 80% of the deaths involved an opioid. An even greater number is sadly expected for 2017. Opioid overdose is the leading cause of death for Americans under 50. In early August 2017, President Trump, at his Bedminster, New Jersey golf course, vowed to declare the opioid crisis a national emergency. Thus far, it hasn't happened. And with respect to opioids, no one seems to agree on what needs to be done about it. With us to discuss this important issue is Dr. Andrew Kolodny, co-director of opioid policy research at Brandeis University, a leading expert on opioids and opioid addiction. Andrew, you are most welcome.
Thanks for having me.
So our viewers can understand, tell us what an opioid is and where does one find one?
Opioids are drugs that are derived either naturally or made synthetically from opium. So very commonly prescribed opioids in the United States are drugs that contain hydrocodone, like Vicodin, or drugs that contain oxycodone, like OxyContin. And heroin, of course, is also an opioid, and there are, as I mentioned, completely synthetic opioids, drugs like fentanyl, for example, where you don't have to start with opium to make them. They're made completely from chemicals.
Now, is fentanyl often mixed with heroin?
Fentanyl is frequently mixed with heroin. This is one of the reasons why we're seeing overdose deaths soaring among young heroin users over the past few years. In some cases, fentanyl is also being sold as if it's heroin, and there's no heroin in it at all. Fentanyl is also available as a pain medication that's commonly prescribed, and it's used in operating rooms as well.
And so is OxyContin is prescribed as a pain medication, and Vicodin and Percocet.
Yes, so these are commonly prescribed pain medicines, and something many people don't realize is that the effects that hydrocodone and oxycodone produce are identical to the effects that are produced by heroin. An experienced heroin user, if you were to give them oxycodone and heroin in like a blind taste test, and this was a study done at Columbia University, the heroin users can't tell one from the other.
How do opioids operate to cause death?
Opioids can slow down your breathing. They can inhibit the region of the brain that causes us to automatically breathe, and if you stop breathing and not enough oxygen gets to the brain, you'll die.
Are they frequently used in conjunction with alcohol?
Many of the overdose deaths in the United States involve opioids mixed with other drugs that can slow down breathing, which the combination is more dangerous than taking opioids alone. And alcohol or sedative medications like Xanax or Valium, if combined with opioids, or make the opioids even more dangerous. But there are many deaths that can occur just from an opioid alone.
Now, are opioids addictive?
Opioids are highly addictive. They may be among the most addictive drugs that we have. So that just about anyone who takes an opioid repeatedly, if they do that long enough, it's very easy for people to become addicted.
So, would that be true, whether the person is an addictive personality or not?
A great question. It's not true that we only have to worry about a small subset of our population getting addicted. Just about anybody can get addicted if they take opioids long enough, which is different from alcohol. If you think about alcohol, the vast majority of our population can be repeatedly exposed to alcohol and doesn't develop alcohol addiction or alcoholism. And when you look at who does run into trouble, serious trouble with alcohol, often you'll see that it runs in their family. And We haven't identified the gene or genes involved in alcoholism, but we know that there are people who are prone to becoming addicted to alcohol. But when it comes to highly addictive drugs like heroin or nicotine or oxycodone or hydrocodone, for the highly addictive drugs, the patient's characteristics are much less important. It's really the way the drug affects the brain that can cause addiction.
Now, the president and Governor Christie of New Jersey and others have talked about an opioid crisis. Is there an opioid crisis, and what makes it a crisis?
Yes, we do have a crisis.
Is it an emergency?
I would say it's an emergency. I would define the opioid crisis as an addiction epidemic, and in fact, it's the worst drug addiction epidemic that the United States has ever experienced. And when I say that, I'm referring to the millions of people who've become addicted and the tens of thousands of overdose deaths that we're experiencing.
And do you attach blame for the crisis on any of the healthcare professionals who are involved in this process, either the drug companies or the doctors?
There is quite a bit of blame to go around. Yeah. The reason we have this severe epidemic of opioid addiction is because starting in the 1990s, the medical community became more aggressive in the way that we were prescribing opioids. And as the prescribing went up, it led to a parallel increase in addiction and overdose deaths. And the reason that doctors and other health professionals started to prescribe opioids much more than we had previously is that in many ways we were responding to a brilliant marketing campaign that was launched initially by Purdue Pharma, the maker of OxyContin. Ultimately, other opioid manufacturers would become involved in this campaign. So doctors start hearing from different directions that we've been allowing patients to suffer needlessly because of an overblown fear of addiction. We start hearing that if you're a compassionate doctor, you'll be different from those stingy, puritanical doctors of the past that were under-prescribing opioids. You'll recognize that opioids are a gift from Mother Nature and that addiction happens very rarely in patients treated for pain. And if we had been hearing this directly from the drug company, we would have been less gullible. But we were hearing it from pain specialists eminent in the field of pain medicine. We were hearing it from our professional societies, from our hospitals, even our state medical boards, which are the state agencies that are supposed to protect the public from doctors who might prescribe very aggressively. State medical boards across the country began telling doctors, we will not sanction you for overprescribing opioids based on doses or quantities, but we will sanction you for underprescribing opioids.
And sanction you if your patients emerge in great pain.
Yes,
so
yes.
You've got to give them opioids to prevent pain. Now, according to a Princeton study I saw, doctors who came from the lowest rated medical schools tended to prescribe much more than doctors from the best medical schools. Is there anything to that?
Yeah, I think there is. That was a very interesting study that they did. So they found a strong correlation between doctors who graduated from the lowest tiered medical schools. They were the ones most likely to prescribe aggressively. And I think that's very much true today. It's doctors that are more easily influenced that are prescribing aggressively. And it tends to be older doctors as well. Younger doctors, doctors who have graduated medical school in the past few years, do prescribe more cautiously. Many of the younger doctors have come of age during our epidemic. Many have lost friends to overdoses, and they're much less likely to fall for the nonsense that we don't have to worry about addicting patients.
Now, back to Purdue Pharma. In 1996, they spent vast sums on marketing and advertising of opioid drugs and tried to make the case using primarily an article, it was really a letter to the editor of the New England Journal of Medicine, that opioids really weren't that bad. Eventually they were fined by the FDA in one of the biggest cases the FDA ever brought against Big Pharma. I think they were fined $600 million. What do you make of all that? Have they have they mended their ways? Have they now gone back to minding the straight and narrow, or are they still promoting pain-killing drugs?
They're still promoting pain-killing drugs. So they got into trouble in 2007 and paid a very large fine for some of the specific ways in which they promoted OxyContin as less addictive. It was the term that was used was misbranding. In fact, some of their executives were even found guilty of misdemeanor criminal charges for the way they had promoted OxyContin. But unfortunately, that 2007 case missed the bulk of what Purdue had really done that created our epidemic. What really caused the crisis was the way in which they promoted opioids as a class of drug. It was the non-branded elements of their campaign that changed the culture of prescribing opioids. It was the way in which they promoted opioids as a class of drug as safe and effective for long-term use for common chronic conditions. And because that 2007 settlement missed the worst of what Purdue did, after they paid their fine, they were still able to continue promoting opioids as safe and effective for conditions where they're not safe or effective. And something we're now seeing is that as prescribing leveled off in the United States, and it's begun to come down a little bit, Purdue is now using their same playbook in Europe and in Asia, promoting opioids as safe and effective for common conditions like low back pain, where we really shouldn't be prescribing opioids.
Now, is this a substance abuse problem? Are opioids taken recreationally, or are people just take them because they become addicted?
It's a great question. So our opioid crisis is an addiction epidemic, meaning that the reason we're experiencing record high levels of overdose deaths, the reason we're seeing heroin and fentanyl flood into non-urban areas, the reason we're seeing a soaring increase in infants born opioid dependent, children winding up in the foster care system, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems has been a very sharp increase in the number of Americans who have become opioid addicted. Now, once somebody becomes addicted, they're not doing this because it's fun. Once you're addicted, you have to keep using opioids to avoid feeling awful. Now, it is true that some people became addicted to opioids because they were taking the pain medicines to enjoy the effect, but many people also developed their opioid addiction taking the medicines exactly as prescribed by doctors.
Now, suppose I go into the hospital for a back operation, and the doctor gives me Vicodin, a Percocet in the hospital, and then says, if you have any discomfort after you're discharged, continue taking it. And he gives me a walloping prescription with lots of pills. How many pills do I have to take before I become addicted?
That's a really good question, and we don't have an answer to it. What we do have better information about is something that we call physiological dependence on the drug, meaning you'll feel pretty sick when you try and come off. And physiological dependence, that feeling sick when you stop the drug, is one of the reasons opioids are so highly addictive. It's a negative reinforcement if you try and stop. Physiological dependence will begin very quickly. If you take an opioid a few times a day for as little as 5 days, physiological dependence begins to set in. And we know that 1 in 5 people who take an opioid every day for 10 days are still taking an opioid over a year later. And if you take an opioid...
Because of dependency.
Hard to say from the data, but yes, I believe because of the physiological dependence that sets in on the drug. Yeah.
Okay, so I take a few pills so that I don't have so much residual pain from my operation. How do I know if I'm getting hooked?
Again, that's very tricky. Now, in general, I would tell people that when a doctor gives them advice and prescribes a medication, they should trust their doctor. When it comes to opioids, this is a situation where many health professionals have been seriously misinformed about opioid risks and benefits. So you shouldn't necessarily trust your doctor when they prescribe you opioids. If you've recently had a surgical procedure and you are not experiencing severe pain, don't take the opioid. And for many people who have a surgical procedure, 3 days is usually more than enough to handle the pain from that procedure. And in many cases, even for severe pain, we don't actually have to give opioids. There are other non-opioid pain medicines that can
Tylenol.
be Tylenol and drugs in the same family as Advil. We call them non-steroidal anti-inflammatory drugs. Drugs like ibuprofen can be just as effective as opioids for severe pain.
What about, Andrew, the demographics? Are there any particular parts of the country that are affected more dramatically than others?
Every state in the country has within it counties that are experiencing a very serious problem. The opioid addiction epidemic seemed to have registered early on in the Appalachian region of the United States and in the New England region of the United States, in the regions of the country where OxyContin prescribing took off quicker. But ultimately, we saw opioid prescribing increase around the country, and as the prescribing went up, millions became addicted. In terms of the demographics, we have 3 groups of Americans who are opioid addicted. We have one group that developed their opioid addiction a very long time ago. These are really survivors of the heroin epidemic of the 1970s. That older group was mostly non-white, and it's more often men. And it's in cities like Philadelphia, Baltimore, New York, other regions of the country that got hit hard with heroin in the 1970s. The survivors of that epidemic are still struggling today with their opioid addiction. And because of fentanyl and the heroin supply, we're starting to see overdose deaths go up in that group as well. But in terms of the groups that have become addicted recently, post-1995, we have 2 groups of Americans who have become opioid addicted. Both groups are disproportionately white. There's a younger group and an older group. The younger group is developing its opioid addiction from pain medicine that they were taking either for medical reasons or recreationally. That younger group is mostly people in their 20s and 30s. After they get addicted to the pills, they frequently wind up switching to heroin because young, healthy-looking folks have a hard time getting lots of pills from doctors. And in that young group that switched to heroin, we're also seeing deaths rising rapidly because of fentanyl and the heroin supply.
Why is this group largely white?
That's a very good question. It's not just this group that's largely white. There's this third group of Americans who's opioid addicted that's also white. That's a group that's people in their 40s up through their 80s. That older group is developing their opioid addiction almost entirely through medical treatment. And that older group is dying of overdoses from pain medicines. The older group doesn't have to switch to heroin because they're able to get pills more easily from doctors. The reason that I think our new opioid addiction epidemic, the one that's hit us post-1995, the reason I think it's so white is related to the way doctors prescribe narcotics. Something that we do know is that if a patient is black, a doctor prescribes narcotics more cautiously. It would seem that if the patient is black, the doctor may be more worried about the patient becoming addicted, or maybe they're more worried about the patient selling the pills. And if the patient is white, they're prescribing as if there's absolutely nothing to worry about. So the black patient is less likely to wind up getting addicted. The black household is less likely to have these highly addictive drugs in a medicine chest. And so what I think may be happening is that racial stereotyping is having a protective effect on non-white populations.
It's one of the few beneficial aspects of racial stereotype.
Yeah.
Now, what is the way forward? I know there was recently a 60-minute piece on opioid addiction. Certainly the President and the Attorney General have called for heightened law enforcement, more arrests, more people in prison. And of course, there's education and awareness, which you were really involved in. What do you see as the most important thing that we should be doing?
The first thing we have to really recognize is that the problem is an addiction epidemic. It's not an abuse problem. For many years, the issue was framed as if the problem is that there's a subset of our population that wants to get high off of drugs, and because doctors are prescribing more opioids, those so-called drug abusers are getting their hands on these pills, and we want to stop them from abusing these pills, but we wouldn't want doctors to prescribe less because that would make the problem of pain in America worse. And that's how the issue was framed for many years, and it's a very phony way to frame it. And the groups that were portraying this as an abuse problem and describing all of the harms as limited to so-called abusers were individuals and organizations that were, in many cases, getting money from opioid manufacturers. The problem is an addiction epidemic, and to really address the problem, we have to prevent more people from becoming addicted, and we have to see that the people who are addicted are receiving effective treatment for their opioid addiction. To prevent more people from getting addicted, more than anything else, that really boils down to much more cautious prescribing so that patients don't directly get addicted and so that we don't indirectly cause addiction by stocking everybody's home with a highly addictive drug. So we need more cautious prescribing, but we also have to see that the millions who are addicted can get treatment. If we were to only curtail the overprescribing and not expand access to addiction treatment, we'll see heroin and fentanyl continue to flood in to meet the demand for it by these people who are addicted, and we'll have to wait for an entire generation who became addicted to die off. And we shouldn't do that. So you need to see that treatment, effective treatment, and I'm not talking about rehabs or detox. The first-line treatment for opioid addiction is with a medicine called buprenorphine, which is a long-term treatment with this medicine. It's through better access to that treatment that we can start to see deaths come down. I would say, though, that there is a role for law enforcement, because it's very difficult to get people engaged in treatment if they have easy access to pills prescribed from a pill mill doctor or fentanyl or heroin. If it's easy to get pills, heroin, or fentanyl, and easier to get it than it is to get treatment, many people who are opioid addicted will go for what's easier to get. If you're addicted, you wake up in the morning, you're feeling really sick, you know that you're going to have to use. If you've got a few bucks in your pocket and you can go buy heroin, and treatment is expensive or hard to find, people will continue using heroin. So you want this balance where law enforcement makes it more difficult to access black market opioids or pill mill opioids, and at the same time health departments and policymakers make treatment easy to access.
Now, medical marijuana is not an opioid, is it?
Marijuana is not an opioid.
So is that really the way forward, to legalize medical marijuana and prescribe it for pain rather than opioids?
I don't know that marijuana is the answer to the opioid crisis. It's interesting because there are raging debates in the United States right now about marijuana, both medical marijuana and recreational marijuana. And advocates for marijuana are trying to tout marijuana as an answer to the opioid crisis. The anti-marijuana folks are touting marijuana as something that will make the opioid crisis worse, arguing that it's a gateway drug, and if more people use marijuana, there'll be more people switching to heroin ultimately. I don't.
You have a view on that?
I don't believe marijuana is a gateway drug. I don't believe it will make our opioid crisis worse. I also don't believe that it's necessarily an answer to the opioid crisis. I think we have to prevent opioid addiction and treat opioid addiction as the answer. What I would say, though, is that if I had a patient who was suffering with chronic intractable pain and had tried absolutely everything, I would sooner prescribe marijuana to that patient than I would heroin. And when we're prescribing opioids, it's like prescribing heroin. Our Controlled Substances Act right now isn't that rational. If it was based on science, we wouldn't have marijuana as a Schedule I drug, meaning no appropriate medical use per the federal government, whereas addictive opioids were even in the Schedule III category up until pretty recently.
So if you had your wish list, what would you do to cope with the crisis?
I think we need the federal government to help states out with this problem. You have quite a bit of good work being done on the community and state level. You have many organizations working to expand access to naloxone, which is an antidote for an opioid overdose. And we have states and community groups working on other aspects of the opioid crisis, yet the problem is still getting worse. What we need from the federal government is a massive investment in building out a treatment system that doesn't exist yet. I believe that we need about $6 billion a year to build out these treatment models.
$6 billion a year. So
Yes.
I have a question for you, Andrew Kolodny. And the question is, because we've run out of time, unfortunately, but the question is the Trump administration doing enough to cope with the emergency?
We haven't.
Yes or no?
The answer is no.
Andrew Kolodny, thank you so much for coming by.
Thank you.
And thank you for coming by. Tune in next week for more conversations. I'm Jim Zirin. Take care and all the best.